Here we go.
You're listening to the podcast between doctors and friends.
Hello, hello, hello. Here's to another week of Between Doctors and Friends. With us are Dr. Ray and Dr. Foz, the usual suspects.
Hey, hey.
Hello.
And we have some guest listeners here that may join us or may not. I want to start this. This episode with what's the weirdest thing a patient asked you this week?
Dr. Ray, do you want me to start with this, or do you want to? I'm sort of guessing that what you do means there's more weird stuff. I don't think it's necessarily, okay, I get weird questions all the time that I don't even file them in my head anymore, like they're just like gone. But I did have this is a very classic example of what I struggle with, that in some ways tests my patience. I had a patient who had had a routine blood test done elsewhere. I don't know who, what, where, why. Like, I don't know the story, and brought me a report. And it was a simple report. And this patient had a slightly low blood sodium. And this can happen for a number of reasons. In the average, a healthy adult, it is often due to medications. It's a medication side effect. And it can be a big deal if it's too low, or it can be not a big deal, but we need to do some changes of medication. And this person was on a medication that theoretically could make this happen, but not something seen commonly. So I was like, okay. And then it could also come up for like, I don't like to use the word lab error. It's just like a lab processing problem. Like a lot of these tests are not 100% as accurate as I think everybody thinks. Like there's an error of margin or margin of error, I should say. And there's not like, you just kind of keep an eye on things and all that stuff. So I'm like, well, the first thing we should do is probably just recheck it when you're not fasting, and, let's just confirm this because it's just slightly out of range. So I made it a point to tell this person, this is not related to your diet. This is 100% not related to dietary sodium intake. And I think that's another misconception. Like people come in and they say, I want a calcium test done. And that's a calcium level is often part of a lot of panels that are routinely run, like metabolic panels and stuff. And they want, I want to make sure. I'm like, why do you want a calcium level so bad? Well, I just want to make sure I'm getting enough calcium. What nobody believes when I say this is a lot of these things are not related to your dietary intake. They can be, but that's usually in more extreme circumstances, right? A lot of these electrolytes that we measure are not related to diet. They're related to kind of the hormonal and metabolic milieu that you have going on. They're complicated discussions, but suffice to say, the majority of time when you're dealing with somebody who's otherwise well and not like severely dehydrated from vomiting and diarrhea or kidney failure, those are different circumstances. But a lot of these things are not related to diet. And so I told this person, I'd say, this is not dietary in nature. So I don't want you going home and eating more sodium thinking that's going to help this problem. That's not how this works. So it's not dietary. I'm just going to exclude that it's not your medication. And then literally the next thing out of their mouth was, so I'm going to go home and eat more salt, okay?
Wow. Is there a thing called salt pills?
There are.
And that's not, people shouldn't.
No.
And you just told them. Yeah, you just told them it's not
literally
dietary.
And I said it very clearly. The first thing I want to do is reassure them, this is not, you didn't do anything wrong. This isn't anything dietary regarding your salt intake. So I don't want you to go home and put more salt in your food, put more sodium in your food, thinking that's going to help this problem. That's not what this is. And, that I went on to say the whole thing about, sometimes it's a lab, sometimes it's stuff. Let's just get to the bottom of it. You're not in any grave danger right now. I will figure it out and I will give you the right guidance and what to do. And so what that tells me, and I was just, so I was like, did you not hear what I just said? Like clearly? This person just kind of was just like, oh, and kind of gave me like an embarrassed kind of grin. But and I get it. The one thing I've noticed is I was watching a YouTube thing on like psychology recently.
It's called a YouTube video.
Yeah. Well, I didn't sit down and I didn't sit down and watch the whole thing, but it was funny because it was talking about the differences in generations on like regulatory of like their emotions, like regulation of emotions.
Yeah.
And I think that's really it, is like there isn't like any there's so much panic nowadays about every little tiny thing that they're like there's no kind of like, well, wait, so the doctor just told me that it's not related to my salt. So, okay, that's good. I didn't, I didn't not salt my food enough or whatever, like there isn't any like, hey, it's either all or nothing. There's no regulation of that fear. Like fear happens, but there's no filter where you kind of go like, okay, let me put this in the context of me. It's like, yeah, you know what? Rattlesnake bites are poisonous and I certainly never want to be bit by a rattlesnake and I'd probably be scared of rattlesnakes. I'm not sitting here in my home scared of rattlesnakes because there's no rattlesnakes in my home. You know what I mean? It's like, there isn't like this unbridled fear that's like,
you should just told them, there's this Filipino preserved plum and it's red. Go search for it, and if you could find it, it's really salty, get a bite.
Okay, see, you did exactly the same thing.
Exactly, I know. If they insist that they want to eat more salt.
You just did exactly what and I just told you, like, hey, homie, you're not in any grave danger. I gotcha. Like, this is not a big deal. And I can fix it even if we come, I can fix this. Like, this is not going to harm you. I will not let it harm you. And like, it was just immediate, like, I was just like, I just spent 2 minutes telling you how not to worry and it's okay. And I'm going to tell you why you don't need to worry. And so when people say, well, my doctor never says anything, they just come in, grunt, throw some pills at me and then tell me to get some labs or something. I said, well, yeah, it's because of this.
Yeah.
It's because when I do take the time to try to explain, you don't ask me intelligent follow-up questions or you don't express any other curiosity about it. You're just like in complete like emotional meltdown. And I'm just like over something like this. And then I think, wait till something really serious happens. But you are going to be hospitalized for psychiatric reasons because you can't handle it. Like, I just sort of, there's no, like, I can't explain it. And it was so frustrating for me. Like, it was really frustrating because there's nothing else I could have done to facilitate this communication any more gently or any more clearly. And it was, I don't know. How do you feel about things like that, Dr. Ray? I mean, that's why people my doctor's saying it. Yeah, because when we do, it doesn't help. You don't listen. You don't have any trust or whatever the problem is. And then you frustrate me.
Yeah, I think that sometimes they hear certain things that aren't said or they perseverate on one word that we say. I think a lot in any kind of relationship, you kind of go in with preconceived notions and you sort of hear what you want to hear, but you're not really listening to what the person is saying to you. So I see it a lot when I tell patients about like for example, maybe their abnormal pap smears or their abnormal biopsies. And I tell them, you don't have cancer, but what you have are some abnormal precancer cells that, if left untreated, could eventually develop into cancer. But we're not going to let that happen. We're going to go through this process to prevent that from happening. And then they'll be like, okay, so I have cancer. I'm like, no, you do not have cancer. And then I go through it again. And then they're like, okay, well, what do I do about the cancer? I'm like, no, you don't have cancer. So I think they kind of hear what they want to hear and they get stuck on certain things. And, they get a preconceived notion that, oh, my sodium is low, that means I need to eat more salt. And they'll listen to you telling them, whatever it is. And then they'll be like, okay, so back to I need more salt, so I think so you have to just kind of be very careful the way you talk to them. And I think you have to say it several times and almost make them repeat it back to you, which is, I think, a technique that we learned back in medical school. Just say, okay, why don't you tell me a summary of what we just talked about? What did I recommend for you to do? What's your understanding, and then you can see if they truly understand. Not for everything. Yeah, not for everything. It's only when they are not understanding what it is that I'm telling them, so if I say, no, you don't have cancer. Okay. Can you repeat that back to me, that you don't have cancer? And then they'll be like, okay, so I don't have cancer. Exactly. You don't have cancer. This is what you have. You have cervical dysplasia that could lead, I tell them, if you move to a desert island and you live there for 5 years, maybe in 5 years you would have it. But because we caught this problem early and we're going to do this treatment, you are never going to get to that point, so it's just a misconception of what,
it is,
what you're saying.
But it's interesting. It's interesting because, of course, I think when you drop in the C word, right, into things, like automatically people are going to fixate on. And that's why I always tell you, bring somebody with you to your doctor's appointments, especially when it's something potentially serious, because then you have another set of ears that are listening, somebody who is objective, I get it. But for this, I can't put up with, okay, parrot back everything I just told you for every patient. I mean, I obviously also do have to use those techniques, but sometimes it's too much. It's just too much. There's an absolute lack of common sense. Absolute lack.
Well, I have to say that as a patient who I get nervous when I see the doctor, and so maybe some patients are nervous enough, and I think certain words kind of trigger.
It's yes, absolutely, we understand that, but everybody every day is nervous for every interaction. Everybody every day for every interaction. So that's why your doctor gets to be like, okay, just here, take these by, and then, oh, doctor, don't communicate with me. It's like, well, yeah, we tried, but you're the problem.
Okay. And have you ever done this line from Harry Met Sally, where a patient would say, am I gonna die? And then you respond with well, eventually. Are you allowed to say that?
I say not today. I kind of played off as a joke.
Yeah, it depends on the patient and my mood and everything, so yeah, I mean, I've probably said something like that before just to be facetious.
Or I joke it off. I'll be like, this is not that serious, I kind of do that sort of thing. I kind of jokingly redirect, because, I mean, the truth is, yes, you will die.
Yeah.
Hopefully not today.
Yeah.
Hopefully not next week.
Or I'll say, yeah, maybe from this.
The last thing I want to do is throw fuel on the fire, so I just kind of.
I have one more comment regarding your story, Dr. Foz. That patient has low blood pressure. It seems like you need a blood pressure machine at home.
No, it's sodium. No. Blood sodium, not blood pressure.
Okay. See that? I didn't listen.
See?
Because I'm a doctor, so I don't listen. But it seems like, when people have low sodium, what are typically the reason for it?
Typically the most common cause of hyponatremia is a side effect of medications, typically thiazide diuretics. Or, usually thiazides.
And in English?
So, blood pressure medicines, certain classes of blood pressure medicines.
Got it. Okay. Oof.
There are other causes. There are hormonal causes of it, and those typically involve it's called SIADH. That's another fairly common cause. It stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion. And so there's a a bit of a hormonal imbalance. And typically those patients are managed actually with fluid restriction and not extra sodium. But that's that is not, when I say it's common, it's not unheard of. In the outpatient arena, it's not as common, but, but generally it's blood pressure medicines. And then also, some psychiatric medications theoretically can do that. So SSRIs for depression and anxiety. But those are, I don't really see that with that. I mean, I've only seen that really, I read about it all the time and I worry about it all the time also, but I only have really seen it in play once in somebody who had other stuff going on. So,
okay. All right. Well, Dr. Ray, what's the weirdest thing a patient asked you this week?
I was trying to think of something. I think I get asked weird stuff all the time, and so I just don't register that it's even weird anymore. But a patient asked me something about if she could hold her period back, like how you would hold pee back by kind of doing like a clenching, and if that would prevent her period from coming out. So that's the only thing I can think of that was a little on the odd side this week. I think she was going to go to some event and she didn't want to wear, I don't know why she didn't want to wear a tampon or something. And she was like, I might start at the event, so can I just clench and hold it back? Something to that effect.
Relatable.
Yeah.
Detailed high school biology.
Yeah.
So will taking iron pills help hold it back, or just like, are you kidding me? Where'd you get that idea like that?
No, iron pills don't have any effect on your flow. Iron pills are meant to help with your anemia in your blood if you're iron deficient.
So there's really no way to hold it back.
Mm-mm. I mean, you can use a tampon or a menstrual cup, and that keeps the flow, from coming out of the vagina, but there's nothing to stop the flow from flowing.
Or get a hysterectomy.
Or yeah, exactly.
Sorry, that's just a really odd question, but
we've all thought about it.
Trying to put it out there because it sounds like they just need hormones to kind of delay it.
Yeah, I mean, if you're on birth control pills, you can do continuous birth control pills and delay your period from coming. But if you're not on any medication, you can take progesterone medication to delay your period, but you have to take that, a certain amount of time before your period starts. You can't take it the day before and then expect your period to stop.
Wow. I mean, really, that's, a realistic thought I think every woman has thought about.
Yeah.
Oh, yeah.
I think the advent of oral combined hormonal contraception is like a true medical miracle.
Yeah.
I mean, I really do. I think it's like an amazing tool.
Oh, yeah.
I think, that's the other thing. So the fear of birth control pills. So, I'll share my experience with patient care regarding this and then see if this mirrors what Dr. Ray does. So I'm very into, when you are a female patient, you get female doctor, you get a lot of female patients. That's just how it is, right?
Mm-hmm.
And so whenever I have somebody who's in their reproductive years, I want to make sure we do things that don't affect their reproductive capacity or a healthy pregnancy for them, right? So if there needs to be certain medications, like blood pressure management or something, they need to be the things that are thought to be safer in pregnancy. Just examples like that. And if I have to put them on something for like mood or example, I'm going to be like, hey, we should probably do this one because it might be safer than this one. Just junk like that. And, so whenever I have a new patient that comes to me and they're female and, okay, are you sexually active? Okay, what are we doing? So if I ask, what are you using for birth control? Automatically I get mad responses. I don't take birth control pills, like mad. Okay, I didn't say birth control pills. I just said birth control. What are we doing for contraception? Then I don't use birth control pills. Okay, I didn't say anything about birth control pills. So now my approach is, what are we doing to not get pregnant? I have to say it like that, or there's this like tirade about how they hate birth control pills. And I think that's weird. I think that's really weird. And I think what is lost is some of the health benefits of birth control pills in an otherwise healthy candidate. Um, lighter flows, less pain, predictable periods, potentially less mood swings, you cranky pants. Um,
With that kind of response, right?
a reduced risk of ovarian cancer if you've been on them for a while, a reduced risk of endometrial cancer. Like, nobody talks about that. Everybody's terrified about manipulating their hormones, and they want to know about their AM cortisols, of which they don't know what any of that means. But everybody's scared to death of birth control pills. Like, and yes, there are potential problems with it. Yes, they don't work out for everybody. But the beauty of it is if you don't like it, you can just stop and nothing bad happens. So I don't push birth control pills. I don't push any method of anything. I want to know where the patient's coming from. But don't get so mad at me just because I asked you what you're doing so you don't get knocked up. So, because then the next person who says, well, we don't do anything. And then I
they don't want to be knocked up.
Well, I said, well, you know what, so what do you want? Are you looking to conceive? No. Okay, so you're not doing anything? No. Okay, maybe you should take some prenatal vitamins because you might get pregnant. Like, it's unbelievable how much, like, and then I'm like, look, make sure you're getting some folic acid on board. Have you thought about the fact that, 50% of all pregnancies in this country are not planned, and that's probably not the best circumstance for you. So think about these things. And that's what happens when you ask people if they use contraception. Okay,
Yeah, I had an old.
Are not planned.
I'm frustrated. You can tell how frustrated I am this weekend.
I had an old attending who would ask the patients, like, what are you using for, birth control, pregnancy prevention, whatever. And if they say nothing, they said, oh, are you trying to get pregnant? And they would say no. And he would say, well, if you're not using birth control, you're trying to get pregnant. So it's kind of like one or the other. Either you're, trying to not get pregnant or you're trying to get pregnant. So and if you're just sort of ambivalent and not using anything and having unprotected sex, then at some point you'll end up pregnant.
Well, then the other thing is like, so it'll end up being like, oh, well, I use condoms. I'm like, okay, that's contraception, people.
What is the safe age for young women to start on birth control pills? Or is that political?
No, I mean, I'll start them on girls as young as 12, 13 if the situation requires it and the patient and her parents are on board. So there's really no age limit. And I've kept them on through menopause till, maybe 55. Some of my patients will go to.
Mm-hmm. Okay.
Yeah, I mean, I've done very quite young teenagers because they're having problems with like heavy or irregular bleeding, or there's a lot of reasons why you would, they're not just used for contraception. That's the other thing too. Yeah. Acne management, it's great for acne, heavy bleeding, irregular bleeding, polycystic ovarian syndrome, like all that stuff. Like there's, a lot of reasons why you would put somebody, or just somebody who has just terrible, painful periods, endometriosis, or just plain old, I hate my periods and they hurt. What can we do about this?
Well, speaking of that, what causes the pain and, the cramps that women experience?
Oh, there's a variety of things that can cause that, just from, inflammation, endometriosis, ovulation. There's a lot of
the typical, like the primary dysmenorrhea, which is like the typical cramps that are not associated with any other thing, because you get anatomical reasons for it, like Dr. Ray was saying. But it's basically what happens with like the hormone cascade that happens that triggers the period. And it triggers like a vasospasm in the lining, in the uterus, and you basically kill off part of your uterine lining, and that's why it falls out like it does is the period. And so that's painful. But it can be managed. Like there's no need to suffer.
Mm-hmm. Well,
the wonders of modern medicine.
Yeah, speaking of anatomical, have you ever had a patient where their anatomy is kind of like reversed, like where their heart, if your heart's supposed to be on the left, their heart's on the right? you know.
I know where this is going.
I've had a few babies that they've found that on. And
Really?
have I had a patient? I feel like I've had one or two.
I think I had one, like it was something like, it was one of those things where I came across it and it was like maybe my partner who was only doing urgent care at the time, like, oh, look at this. Oh, that's cool. Okay, everything is fine. Yeah, we got the x-ray because of like a cough or something. But the patient already knew about it. It was something like that. And it was some sort of like, it wasn't really my patient. So not really.
Mm. You know, allegedly, you know, we lost the actress Catherine O'Hara. Allegedly, that her anatomy was that way. You know, the driver's seat's on the other side. But that doesn't cost anything, right?
Technically a birth defect.
Oh.
You know, I don't know anything about it really. I don't know if Dr. Ray knows more about it than I do. There wouldn't be anything that I can think of that would directly be a danger, except, well, see, nowadays, it's not as big of a deal. You know, like if you have something that looks like appendicitis, then, you know, that's classically like what they call, you know, abdominal pain that localizes to the right lower quadrant over a period of hours to days. And so when somebody comes in with right lower quadrant pain, like that's one of the first things that should come to our minds as providers. But, so if somebody who had, you know, the inversus, like it would be on the left side. And so your doctors may not necessarily be as clued in because a lot of what happens, especially in the abdomen or, you know, it depends on the side of it, right? Like if you're like gallbladder pain, right? That's typically right upper quadrant pain or, sometimes in the middle, but more like off to the right. And so it may kind of interfere with the diagnosis of things like that. But, you know, in modern times, you know, pretty much anybody who's got suspected appendicitis is going to get a CT scan, so they'll be able to be seen. Whereas in the past, when CT scans were not as readily available for everybody who had appendicitis, and it was mostly a clinical diagnosis, like, oh, you have the classic symptoms, we're taking you to the operating room. Occasionally they'll go to the operating room and they'll go, wasn't your appendix, it was something else. So here they'd be like, well, oh, you could miss an appendicitis because of that. But once again, I don't think that's a huge danger, at least in this country, in developed parts, like our non-rural, like places that don't have access issues to healthcare. I don't think it would be a big deal. Now, in other parts of the world or places where there may not be, you know, if you're practicing in the middle of nowhere and your nearest hospital is 200 miles away, and you know that can be a problem.
And so is that easily diagnosed, or you have to go through a CT scan for that?
For appendicitis?
No. What do you call whatever that?
Inversus, whatever inversus.
Oh, situs inversus.
Wow. Okay,
yes,
yeah.
I think. Well, I mean, it would depend because if somebody listens to your heart and be like, "Wait a minute, things aren't where they should be," there could be clues like that because it would be reversed. And then if anybody ever ran possibly like an EKG or something, it would also look like, wait, what? Like, I think it would freak everybody out first because they'd be like, okay, clearly whoever put this EKG on there needs to be retrained. That's the first thing that would happen. Like, some poor staffer would probably get in trouble. But, like, but, I mean, it's not like everybody needs an EKG for every, you know what I mean? So it is possible that somebody can go a good chunk of their life and have it missed. That is entirely possible.
Wow. Now it's making me wonder, what about like left brain, right brain?
No, that doesn't change. that doesn't change at all.
Well,
Really?
See, it's like things like, you know, like if somebody has, I was thinking like the abdominal pain thing, right? Like one of the things I always think of is that ovarian nature, if it's a female power, it doesn't really matter if it's your left or right ovary, right? It doesn't matter.
All right.
So
Dr. Ray,
it also doesn't matter.
Dr. Ray, you said that you've had maybe babies that had it?
Yeah, because they do anatomy ultrasounds on babies. So we look at all of those things for prenatal diagnosis. So part of the anatomy scan is looking at like the heart and making sure there's 4-chamber heart. And so they're able to tell the side of the heart on the baby. So it can be diagnosed in utero now.
It's fascinating. I've never even heard of this until this week.
Did those pregnancies continue normally?
Yeah. Yeah, it's just sort of a incidental finding. You know, they're looking at, you know, the heart, and then they look at the liver, and they look at the kidneys, and they look at the stomach bubble, you know, make sure there's no pyloric stenosis and all of that stuff. And so they can tell, like when they're scanning, they know like, oh, I'm scanning along the right side of the baby right now. And, oh, that's not supposed to be there. That's supposed to be on the left side. Oh, wait, isn't the heart supposed to be on the other side? Like, you know, they'll pick it up. So I've had them pick it up. It's incidental. It doesn't, as far as I know, it doesn't cause any medical issue, doesn't cause any problems, doesn't lead to death, doesn't lead to anything. It's just, you know, you have to know that so that when you go into the emergency room and you say, you know, you have right lower quadrant pain and everyone's thinking, oh, that must be appendicitis. You're like, no, my appendix is on the left side. So it's different, you know, so just to let them know. And, you know, when they're,
I would recommend the medical alert bracelet.
Yeah.
Just to be on the safe side for that.
Yeah.
But
it's an interesting finding, but it has, as far as I know, it has zero to do with anything.
Yeah. I just think it could lead to a misdiagnosis or a delay of diagnosis because things are not anywhere near what we would normally expect them to be. But also the point to know is that fetal surveys that Dr. Ray is talking about are standard of care now, but they were not when Catherine O'Hara was in utero. Like, they were not when we were in utero.
Right. Mm-hmm. Right.
So it's a modern times finding. So once again, in modern times, in modern places with easy access to good prenatal care, this would not be something that would be a surprise later on.
So would that be, and again, just so ignorant here, their heart, even though their heart's on the right, would their heart be kind of flipped, you know, horizontal?
Like, everything's a mirror image.
It's just exact mirror image.
Wow.
It still functions the same. Everything works the same. It's just a mirror image.
Nice. Wow. Fascinating. All right. We're going to try something new here. We're going to do a headline roulette. So, just going to try to get your reactions. I'll read some headlines that was in the news this week and, give your reactions. All right. Let's try this. So the first one is the CDC changes the childhood vaccine schedule again.
Thumbs down.
Why? Well,
I don't know what.
I'm kind of speechless. It's you know, that is just very political. It's because of who's in the White House right now, who is the Secretary of Health and Human Services right now. It's not based on medicine. It's not based on research. It's not based on, you know, the American Academy of Pediatricians recommendations. So this is, you know, this is just ridiculous. I think most of the doctors just feel like this is just ridiculous. And I think we're just buying our time for the next, you know, 3-4 years. And hopefully we'll have somebody more sensible in the, you know, Secretary of HHS position, and they'll go back to the standard vaccine recommendations.
It's not based on any real science. And the other thing I will say is the fear surrounding vaccines is unexplainable by actual any negative outcomes. And that's what I don't understand is it's bad for kids. It's bad for us as a nation. It's bad for society. It's bad for the world as a whole. So, leading medical organizations, American Academy of Pediatrics, American Academy of Family Medicine, American College of Physicians, I know that there's the Western State Alliance, I think New York, I think there's a whole bunch that are just not, that are like developing their own recommendations that are based on science and stick with more of the traditional vaccine schedule that has been in place for. There's tweaks, there's ads, and all that stuff that's been there. So
Wow.
we're not lost because the CDC says something. But what's really terrifying to me is the CDC, in the eyes of medical professionals, has lost a lot of credibility, and that's really difficult. You know, because I actually, prior to any of this, like I actually have a great deal of respect for the CDC. Well, now I don't, and so it's kind of like. I feel like Dorothy, who then got to Oz and looked behind the curtain, and it wasn't a wizard.
I know. Well, we have a friend here with her hand raised. Go on.
Thank you, friend. I have a
It's between doctors and friends, you know. To be
I'm the
clear.
other friend. I just want to know, like, at a patient level, how is this affecting insurance when it comes to, you know, what's covered by insurance? Does insurance, is it lockstep with the CDC, or is it lockstep with the, especially
medical
for
board.
California patients, the West Coast Health Alliance? What do you guys
That's
think?
actually an interesting question because I actually don't do any peds anymore. I used to do a lot. I don't do them anymore. I think this also puts insurers in weird places because it is in their best interest to vaccinate all of their patients, including their children, against these diseases so that they're not getting claims for illnesses on these things, right? Like, can you imagine if somebody I don't know what would happen with the insurance situation if somebody comes down with measles and then has a complication. That would be a very expensive bill because it would require a lot of, isolated care, so to speak. I don't know how that's going to work. I think that when the vaccines when they're no longer recommended. I think that a lot of the status of these vaccines are that they're kind of more like recommended discussion as opposed to you should still have it. So I think it may still be covered, but that's a really good question.
Good question.
Well, because a lot of times if I have a patient who has an indication for a vaccine that's outside of a situation like if like meningococcal B vaccination, if somebody's going to travel for the Hajj or something, I haven't had a problem getting it covered. Like knock on wood. So, where I have had issues are things like depending on somebody's insurance, like can you get your vaccine in the doctor's office? Does your doctor have that vaccine? Or instead do you have to go to a pharmacy to do it because of your Medicare or whatever the situation is? So, I don't know, but at this point, because they're not saying these are no longer recommended at all, you should not do them, I think then the insurers don't have that. And I also wonder what kind of backlash insurers would get if they were not covering vaccines. Because if I was a parent, I'd be like, look, hepatitis B has been a part of the standard since 1995. Just this year, they're saying maybe it's optional and you're not going to cover it. You better cover it. So I think, and that's not cool if you have to fight back, because that removes access. And I will remind people that there are other ways to get vaccines. If your doctor won't write them, you can always see a different doctor. You do have that choice. You can always pursue things through your county health authority. They will often have resources for people who, even if you're insured, they can maybe figure out a way for something to happen.
Dr. Ray?
Yeah, I kind of agree. I don't do that much with vaccines other than, for pregnant women, flu vaccine, COVID vaccines, RSV vaccines, and for non-pregnant, talking about the HPV vaccine. But I don't really do too much with it to comment.
Okay. Let's move on.
Hold on. So things like the hepatitis B vaccination, that is not one of those like vaccines in the adult vaccination schedule that must be done. But I routinely test and vaccinate for hepatitis B and have done so for the last 20 some years. And I haven't ever had it not covered by insurance. So I I'm hoping that it's not going to be an issue.
Yeah.
Is like the COVID vaccine, is that still covered by insurance or no more?
I think there are some criteria that they now want you to meet in order for it to be covered, but I have not delved too much into it. You know, I think it, for the most part, it is still covered.
Okay. Well,
Yeah, I think there's workarounds, and then also, you know, a lot of the things that would make it covered are not, like, if anybody has any psychiatric history at all is one of the reasons, because they have a worse outcome with COVID. So, like, do you have a history of anxiety? Yes, I do. Okay, here's your COVID vaccine. Like, I don't think,
oh,
like, there's kind of, you know, remember that your healthcare providers will, they want you protected. They want you vaccinated. They want you to get what you need. And so we generally, we will work as a team to try to make things happen.
well, speaking of that, there's been the flu, the cold that's been going around,
A
and
lot of flu this year.
a lot
A
of
lot.
flu.
Flu A, yeah. It's been
And
ugly.
yeah, I heard it's bad, right?
Yes.
Are you seeing that?
I am where I am at geographically yet.
I'm not seeing it too bad. In my patient population, I'm not seeing it too bad. And in my personal circle, I'm not seeing it bad. So it might just be, again, geographic location.
Now, what about those people in Minnesota that's protesting at -8 degrees out there in the cold? What can they do to
That means
protect themselves?
they're passionate, first of all. They're
Uh-huh.
willing to. And then, I mean, people have lived in very cold areas for millennia, so people who live in northern climates generally know how to deal with cold.
Wow.
You may not be able to handle it, but I'm sure they can.
Yeah, I mean, being out there for that long, right? And, you know.
Yeah.
All right.
Well, I'm sure that they have, you know, all kinds of, you know, gear and equipment and take indoor breaks and, you know, and then also there's the safety in numbers thing, right? So if somebody seems like they're getting into a bad shape, there'll be people around, hopefully, to help.
Yeah. And chapstick. Let me move on. OB-GYN subspecialties are exploding. Why is everyone suddenly doing MFM? What is MFM?
That's maternal fetal medicine, but I have not heard this. What headline are you reading, or what's your source?
It's just one of the headlines that hot topics for this week. But okay.
It's also known as high risk obstetrics, and so those, yeah. Every MFM doctor I've ever met in my limited exposure to them is stinking brilliant.
All right, we'll move on. Next one. Oral weight loss meds are everywhere. What's hype versus helpful? Oral weight loss meds.
Yeah, so I don't do weight loss medicine at all, but I am hearing, the GLP-1s like Ozempic are now available in oral form. And I think I saw a commercial that said you can get it at Weight Watchers now. But I don't know too much about that since I don't do weight loss medication, but it's probably good. I hope that it will mean that the coverage is going to be better. Hopefully maybe less expensive in a tablet form versus an injection, and therefore more accessible to people. Because I know I have a lot of patients and a lot of friends and a lot of family who can't get on it. Insurance won't cover it. So they pay out of pocket, or they get it from a foreign country, or use a compounding pharmacy or something. So it would be nice if it is possibly, oral form that's more readily available and able to help out the patients who need it.
Is that related to microdosing? What term? Why is it microdosing like a thing now?
Yeah.
Or is that marketing?
So,
Uh,
there's actually some science behind. There's a little bit of emerging evidence on. So microdosing just means using very, very small doses of the medications. Typically, remember at this point, except for the newly approved oral versions, there's only all of these meds are injectable. So microdosing just refers to the minimum doses you need to maintain weight loss. So the idea is that you lose weight on the injectable weight loss medications, but if you stop the medications, then the weight mostly comes back. Like, it'll come back. And there's some thought that once you achieve what your goal weight is, that perhaps you don't need as much to maintain it as you did to achieve what you need to be at. There isn't that is not being put into practice at this time. Like, there's no, like, okay, the standard of care is you get put on Wegovy or Zepbound or whatever, and then after X amount of weeks, we're going to really reduce your dose. And it does become difficult with some of these because, um, for the most part, they come as a pen that can't be altered. That's, once again, there's more complicated discussions related to that. And Zepbound does now also come as a vial that you have to draw up yourself. And so then you could microdose that. So then you have to worry about like sterility of your sample because it's a vial. You have 30 days to use it, blah, 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 blah. And so that's where the microdosing comes from. What I'm concerned about with the oral is it's not like it's free. It's not like it's way cheaper, super duper because it's injectable. I do have a good amount of experience prescribing oral medications for diabetes management, not for weight loss. And I've found that side effects have been prohibitive for this in the past. It has been reformulated, and I think that's a good thing, and we'll see if it's more effective. Now I'm starting to worry about people who are going to abuse it. Because they don't have a medical indication for medical weight loss management, but they just want to now be a size 2 because they can.
Well, with the GLP-1, everyone's kind of like that's the Ozempic look. There has been videos and photos of Ryan Seacrest losing a lot of weight, and everyone says it's that. Not everyone, but many people say it's that. I don't,
Really?
it's not for them to diagnose him, but what
Is it because he looks, so I don't know a thing about this. Is it because he looks leaner, or is it because of does something look wrong?
Yeah, I mean, what is that look that, just to educate, some people, they could be sick, they could be going through something else.
I'm going to say this. I have used a lot of these meds in diabetics for several years now, and they have absolutely been groundbreaking in terms of the control that you can achieve with these medications. When it comes to some of these like blood sugars, it's amazing. Mm-hmm. It really can make a huge difference. And the other thing I will say I know this is going to sound weird. It's very common for me to get people who come in and you find out that they're diabetic and they have cholesterol issues and blood pressure. Like, there's all this stuff, right? You're like, okay, we need to really do some work to improve your metabolic profile so that we can improve your health overall and reduce your risk of complications, right? And sometimes it's really hard to get on board. Like, that's not like okay, you're here, here's your meds, you're motivated. Very rarely do I have patients say, okay, give it to me, doc, give me all you got because I want this to go away. Usually when I have patients who are like that, they're people who, like, everybody in their family has this problem and they kind of knew it was coming for them. So they're kind of already like emotionally comfortable with it, right? Mm-hmm. But a lot of times it's a struggle. It's like, I don't want to be on meds or this and that. I get it. I understand. Like, I don't, truthfully, I don't like to give anybody meds. I would like to tell you were fine and I'll see you next year. Like, call me if you want to have coffee kind of stuff, right? But like, that's it. Like I just feel we're not happy about it either, but we have to address what is in front of us. So you finally get patients to agree to try some of the stuff because getting people to understand injections is difficult. Now, I will say this, that the injectable medications for weight loss are subcutaneous injections. That is very different than when you get a shot for a vaccine, which are usually intramuscular. There's some that are subcutaneous, but most are intramuscular. And then, or getting a blood draw, which is intravenous. Those are different routes. They're bigger needles that go deep. Subcutaneous needles don't go that deep, so it's kind of not that big of a deal. So once you kind of get people past some of these ideas and like, it's really, they'll come back and over time, like I'll see people, and 3 months into it, 6 months into it, you don't see them every day. So they come in and I don't say they look, people talk about Ozempic face and they look gaunt and all that stuff. And I don't know if that's what you meant by those pictures. They don't look like that. You know what they look like to me? They look vibrant. I know how this sounds. Like, how would you describe that? They just look vibrant. I don't have anybody who comes in and they just look better. I almost feel like
Yeah.
fixing them metabolically is not supposed to do anything to you cosmetically. I'm just going to say that's not, there's nothing like that, right? But, well, I mean, unless you just look better because you're leaner, but they just look brighter. That's the only way I can describe it. I'm going to guess that all this talk of Ozempic face, and I have seen it happen in a few people who have been doing it just for weight loss. It's the rapid weight loss. I've seen it in people who lose weight who are not on these. So I think my personal opinion, and this is not based on science, this is just based on my opinion, is that maybe we should go slower. Everybody wants to they start on like Zepbound and they lose like 5 or 8 pounds in that first month. They're super excited and now they're like going to do it again. And then, let's go up. They're like, come on, doc, let's move this along. And you're just like, whoa, wait, maybe just slow your roll a little bit. So you can have more things like you're going to lose the fat in your face if you are losing weight rapidly, or even if you're not, eventually it'll show in your face. And so if people are saying that certain people might look more gaunt, it's entirely possible from something like that, or somebody can be ill. It's hard to know, or they just change their lifestyle, I had at one point been very strict about my diet and exercise, and I was running a lot and doing all stuff, and I definitely could see it in my face. I was like, this isn't really kind of what I wanted. But I'm like, well, that's okay. I feel better, so.
I mean, with like Chadwick Boseman, he lost a lot of weight and turned out that, he was fighting cancer.
Yeah, you never really know what's going on with somebody. So I think people in, his inner circle hopefully are looking at him and taking care of him.
So don't judge.
And then, right. And I mean, the thing is, I don't know if everybody's got an opinion.
Yeah.
You're entitled to your opinion. And I don't, I just hope that it isn't from illness. And the thing is, this is, because GLP-1s are kind of like the hot commodity, right? And that's the cool thing to do. People who have a lot of money are going to have easier access to these things, even if it's not indicated. Look at what happened to Matthew Perry.
I was going to say, our generation, Matthew Perry, the change in weight, right? Weight loss and such.
Okay. Well, that's what happens a lot with substance abuse, right? Is that you can go either way. I've known people in my personal life who I can tell where they are with their substance situation by how much weight they've gained or lost.
Really?
Like, okay, you must be eating again because you're looking skinny and not well. And when you're looking the other way, then okay, probably things, yeah. I mean, it's not like it's a one and done, but it's a flag that we can see. And,
well,
I know these people. The people I'm talking about are people I know. So it's not like, I'm just walking around judging patients about this. Like, these are in my personal life.
Well, we'll end this, we'll close this episode with, the headline news that, bacon and hot dog and Pringles and Cheerios, it's like, cut that out of your kitchen. That is the saddest news.
Yeah.
I mean, I don't care about Cheerios, But
Cheerios?
bacon,
I didn't hear anything about Cheerios. I thought they're supposed to be heart healthy.
Cheerios, Pringles, and something else, because they found that
But other chips are okay, right?
I guess they found like mice, droppings on them, a lot of them, and
Oh,
Oh, don't you remember?
so just temporary.
Don't you remember?
yeah,
Don't you remember from our I believe this had to have been from some school days together we had to our host when they told us that chocolate was 2% mouse turd.
yeah, I remember that. Still eat it.
Yeah.
Immunity.
Yeah.
But it's like now I can't even eat a bacon and not think that I'm smoking a stick of cigarette.
Well, what would be worse is if you had bacon and then smoked a cigarette and then had some whiskey to chase it. That would be
Right.
really bad.
And
Followed by some Pringles.
and Los Angeles, our downtown dogs is hot dog wrapped in bacon. What do you guys
Who
think?
does it gone?
Do you talk? Well, it just came out in the news, so I don't know if any of your patients have
Well,
brought this up.
we have known that processed meats
They,
such as bacon
they contain
and
nitrates.
sausage,
Yeah.
yeah, and that all that stuff is not good for you. They are associated with more cancers of the gastrointestinal tract, and they're not recommended for ongoing consumption. That's not a new thing. It might be a new headline, but we know that's the case. We know that processed foods like that, like things that chips and crackers and all that stuff isn't good for you. It's not new. Maybe just
Wah,
new leadership.
wah. We just don't want to see it in the headlines. We just don't want to see it printed. Are they gonna come with a warning sign like the cigarette boxes? Right?
Well, does that
I don't
deter anybody?
think so.
Like that's the thing. Like alcohol has that warning too. Do you read that? Do you care?
Yeah.
That's true. That's true. And sometimes I see a lot of vegetarians and that drink a lot of alcohol. So
Well, I always say that veganism and vegetarianism can be the healthiest way to live, or it can be the unhealthiest way to live because sugar is vegan.
yeah. That's a sad way to live, but I'm not a doctor.
Everything in moderation. Everything in moderation. Don't have
There you
bacon
go.
every single day, but you can have it maybe, once every 2 weeks
Once
or
in a
something.
while.
Yeah, once in a while is fine. But everything is in moderation. If you overeat the bad stuff every single day, every single meal, then that's a problem. But, occasionally having some bacon is not a problem.
So for those of you listening that eat bacon, just make sure you eat the good bacon. Just,
Yeah.
Well, I wonder. See, the thing is we know that red meat isn't good for you, but if the bacon isn't cured, because there's uncured bacon, then what?
Right. Well,
And what would that taste like? What does uncured bacon taste like?
I have no idea.
That would be pork belly, right?